right. Hi, welcome. For those of you that don't know me, I'm Kayla Andres. I'm one of the physicians here at Corewell Health, and I'm talking about ketamine today. I have a lot of content, and last time I did not get through it, and I added even more this year. So there may be some slides that I may just kind of skip over for time, but the slides will get sent out, and so you can definitely read it. I want to make sure I have time for questions to help you enable you to use ketamine in your own practice. All right, I have no disclosures today. All right, our goals and our learning objectives for today is to recall the mechanism of action of ketamine, identify the clinical utility of ketamine, choose the appropriate route and dose of ketamine for your patient, and I want you to be able to describe the current limitation in the literature on ketamine. And so why should you care? Even if you're not going to use ketamine in your practice, there's a good chance that you are seeing a patient who is utilizing ketamine. This is just a sampling of some of the ketamine clinics here in Grand Rapids. And so patients may be getting ketamine infusions elsewhere. And so kind of having a good understanding of ketamine and how it works can help you treat those patients. So we're going to start with a patient case. So NZ is a 54-year-old with a history of traumatic subarachnoid hemorrhage, chronic SDH, alcohol use, and recent diagnosed laryngeal squamous cell carcinoma. He underwent a total laryngectomy, pharyngectomy, total thyroidectomy, bilateral neck dissection, core pack placement, left anterolateral thigh free flap, and a split thickness skin graft from the left thigh. And we were consulted on post-op day 1 to help with pain management. A review of his maps reviewed that the patient had been receiving prescriptions for Norco since about 2 years prior. A few months prior at the time of his diagnosis. He was started on a fentanyl patch just prior to his hospital stay, in addition to his Norco. He was established with outpatient palliative care at that time. He's rating his pain 10 out of 10 on post-op day 1. He was on his home fentanyl patch. He had some oxycodone, IV Dilaudid. And so we made a few adjustments. We increased his oxycodone. We increased his Dilaudid for pain not responsive to oxycodone. And then the next day we saw him, and so this was post-op day 2, and he was only slightly better with his pain still a 7 to 9 out of 10. And he had used about 190 OMEs in the last 24 hours, 3 milligrams of IV Dilaudid, and then 85 milligrams of oxy, and then his fentanyl patch. So what could we do next? Well, we will hopefully be able to answer this later on in our presentation. So ketamine, it is in the class of general anesthetics. It is a Schedule III drug. Despite that, it does still show up on our MAPS reports from my experience. It is a derivative of PCP. It was approved as a use of an anesthetic in 1970. And when we talk about ketamine, we're talking about a racemic mixture. So it is this racemic mixture of this S-ketamine and R-ketamine. And the S-ketamine has a higher affinity for the NMDA receptors than the racemic compound. So if you're using the S-ketamine specifically, generally you're going to need fewer doses and hopefully have fewer side effects. Ketamine is unique in that it is amnesic, analgesic, dissociative, and has sedative properties. It has low protein binding. It's lipid soluble, rapidly crosses the blood-brain barrier. And back to potency, the S isomer is about 4 times more potent than the R and 2 more times potent than the racemic mixture. So how does ketamine work? Well, as I mentioned, it's a non-competitive antagonist at the NMDA receptor. So this diagram shows the NMDA receptor, and at its kind of resting state, it's blocked by magnesium, and it blocks by drugs, and it can be blocked by drugs that act at the PCP site. And so that is where ketamine works, is at this PCP site. And other drugs work there too that you may be familiar with, including dextromethorphan and methadone. And so the NMDA receptor is closely involved with the development of central sensitization of the dorsal horn neurons, which transmit pain signals. So at normal resting membrane potentials, it's blocked by magnesium as inactive. When the resting membrane potential is changed by prolonged excitation, the channel unblocks, calcium moves into the cell, and which leads to neuronal hyperexcitability, which can result in hyperalgesia and allodynia and a reduction in opioid responsiveness. It actually leads to between crosstalk with the opioid receptors and leads to a downregulation of opioid receptors. So in its activated state, this, creates the side effects that we can see for opioid-induced hyperalgesia, with the hyperalgesia, the allodynia, and the reduced responsiveness. And so blocking it can have, mechanistically makes a lot of sense when we're running into that problem. And so the opioid receptor activation results in phosphorylation and opening of the NMDA channel, which, as I mentioned, leads to the opioid receptor and it's being downregulated. It also these were some new things that I actually learned at AHPM on a talk I went on ketamine, is that, and some of these are more related to the antidepressant effects. There is increased brain-derived neurotrophic factor, as well as rewiring of the stress-induced neural pathways. It can help rebalance the GABA and glutamate balance, and then also has some anti-inflammatory effects. And so the brain-derived neurotrophic factor that supports the growth, repair, and survival of neurons, particularly in the areas of mood regulation, like the prefrontal cortex and hippocampus. And then it helps restore and form new synapses, improving the brain's ability to process emotions and reduce overactivation in the amygdala. So there's also thought to be some other effects that aren't as well understood, including dopaminergic and noradrenergic transmission. It's thought that it may also lead to some changes in cellular processes and gene expression. And so there's still a lot to understand about the mechanism, but I think every year it seems like we're learning a little bit more about how ketamine works. And if you're really interested in how ketamine works and you want to get into the cellular level and the channel level and just really get into the details, this article is a really great deep dive into how ketamine works for depression and pain. I think I could spend a whole hour reciting this article, and I don't know that we would be any of the wiser with me explaining it, but if that's what you're interested in learning more, I definitely recommend this article. A little bit more about ketamine. So it has a pretty short half-life. And so its alpha half-life, which is the distribution leading to decreased plasma concentrations, is about 2 to 4 minutes, while the beta half-life is about 2 to 4 hours. And so the beta half-life is the elimination half-life. So we're looking at about 2 to 4 hours half-life. So the short alpha explains why people who receive ketamine for anesthesia can recover quickly. Norketamine has a lower affinity for the NMDA receptors than ketamine. And so that is here one of the major products of ketamine. And so if you have a patient because it does require liver metabolism, if you have a patient who's elderly, has liver cirrhosis, decreased hepatic blood flow, they're also going to decrease the clearance of ketamine and also likely have increased oral bioavailability, which maybe you could use to your benefit, because as you'll see, the oral bioavailability of ketamine is not great. Norketamine has a lower affinity for the NMDA receptors, as I mentioned. And then ketamine, it can cause hepatic enzyme induction, and it can actually enhance its own mechanism. I think you probably see on there, there is some interactions like clarithromycin and grapefruit juice, which are CYP3A4 inhibitors, can increase the plasma concentration of ketamine, and rifampin and St. John's wort, which are CYP3A4 inducers can actually decrease the plasma concentration of S-ketamine. But it's a little bit more complicated because itraconazole, which is a CYP3A4 and a P-glycoprotein inhibitor, do not actually affect the plasma concentrations of ketamine. But just keeping in mind with the CYP3A4 as well. So preparations and bioavailability. So IV is going to be your most bioavailable route. And it is going onset can start in seconds with the duration depending a little bit different. So anesthesia, we're looking at 10 to 15 minutes, but 20 to 45 minutes for analgesia for just a single like push of ketamine. Certainly sub-Q and intramusculars we would expect also have fairly high bioavailabilities, but looking at oral, the bioavailability, I have a range there, 8 to 24. I think the literature now is really saying closer to 20% bioavailability. With the sublingual bioavailability is slightly higher at 30%. And then I just want to call attention to the intranasal bioavailability being slightly better than both of those at 45%, which then will make sense why an FDA approved product for ketamine for depression is an intranasal spray. And switching between, I haven't found a great, if you're trying to switch between routes, from what I've read, if you can switching to parenteral to oral, you can kind of do a 1-to-1 switch if they've just been on it for a short period of time. But if you have someone on ketamine for weeks to months, you may want to reduce the oral dose. And then for oral to parenteral, start low and then just up titrate is kind of the recommendation just because of that poor bioavailability. So. All right, dosing. I really kind of simplified this to just try to get us all on the same page and try getting us using some standardized. There really isn't standard dose strategies. So when you're dosing, a lot of times it is ideal body weight, and I recommend, or it is weight-based dosing, and I do recommend using ideal body weight, not using their actual body weight. And so from the studies, I think a lot more are kind of standardizing to what I'm going to tell you here. So if you are giving an IV bolus, I generally recommend starting 0.25 to 0.5 milligrams per kilogram, and you can go up to about 1 milligram per kilogram. Usually I'm running that bolus over 40 to 60 minutes. I generally do 60 minutes just because that seems like a more rounded number. And just kind of for reference, anesthetic dosing is usually we're looking in the realm of 1.5 to 4.5 milligrams per kilogram per hour. Some experts may say that anesthetic dosing starts at 1 milligram per kilogram per hour of IV ketamine. So just keeping that in mind, I really would try to keep your dosing 1 milligram per kilogram or less. And then you can follow that by continuous infusion. Some people just start the continuous infusion without the bolus, and so that is fine too. Each institution I found has a different kind of policy about how they dose their continuous infusion. So some dose by weight, which is probably going to be 0.05 to 0.25 milligrams per kilogram per hour, and then some just have a set, you pick a milligram per hour. What I find is if you do the math in this range, usually even starting 0.05, I just did it the other day for a patient. If you start that 0.05 milligrams per kilogram per hour, you're probably going to start somewhere in the range of 2.5 to 5 milligrams, which is what I would recommend kind of your starting dose for ketamine infusion. Dosing for sub-Q is going to be somewhat similar to IV. So you can start 0.1 to 0.6 milligrams per kilogram and then do an infusion 0.1 to 1.2 milligrams per kilogram per hour. And then for oral ketamine, I recommend starting a 0.5 milligram per kilogram per day and then dividing that into 3 to 4 doses and increasing upwards to 1 milligram per kilogram per day. And so that would be like your oral or even your sublingual dosing strategy. For depression, and depression is kind of really where a lot of the data, the newer data we have, is going. It's also where we're starting to see a bit more standardization of the dosing. And so this study looked at the placebo, or was compared ketamine versus midazolam in dosing. And so you can see compared to midazolam, which is this top blue line, ketamine had significant, all ketamine had significant improvement in depression at day 1, and that persisted. And then here, when we looked at which doses were most effective, really it was the 0.5 milligram per kilogram dose and the 1 milligram per kilogram dose. There was no statistical difference in the effectiveness, but there were fewer side effects with the group that received 0.5 milligrams per kilogram compared to the group that received 1 milligram per kilogram dose of ketamine. And so that's kind of where, this study, and I think some other studies that have really kind of used that 0.5 milligrams per kilogram, is kind of where I've started really pulling my dosing from, because the lower doses, the 0.1 and the 0.2 milligrams per kilogram, those were not actually superior to the active placebo of Versed. The 0.5 and the 1 milligram per kilogram was, but you're less likely to have side effects with that 0.5 milligram per kilogram. Adverse events. So there's a lot on this slide, but I will actually tell you that I find it's pretty well tolerated. So dizziness is probably the one I hear the most anecdotally. I had hallucinations, particularly as you're getting to the higher doses. Sometimes with the boluses, patients may report some hallucinations or vivid dreams. They usually go away shortly after the bolus is completed. Sometimes it can worsen anxiety, hypertension, tachycardia. I have not seen a lot of increased salivation, but that is a risk. And so those are some of the acute effects of receiving ketamine. A lot of times I leverage the fact that it can cause hypertension to my benefit in patients that are hypotensive, and the medical teams are not wanting to give other analgesia for concern that it may further lower the blood pressure. So you can use some of that to your benefit. You can treat with a benzodiazepine that had an increased risk reduction of psychosis-related events. I would say I do not regularly add benzodiazepines when using ketamine, but that certainly is an option if you're concerned. And then if you're worried about the increased salivation, you could add atropine or scopolamine to help with that. There are some long-term risks with ketamine, including there's many case reports of interstitial and ulcerative cystitis for patients that chronically use ketamine. Usually this is patients that are abusing ketamine and not being prescribed medically ketamine, but I think it is something, because we haven't prescribed ketamine long-term, is just in general. And so I think it is something to keep in mind and just watch out for. There is some risk of addiction, hepatotoxicity, and then neurocognitive impairment, particularly in spatial and pattern recognition. I have been asked if it prolongs the QT, and there has been some case reports. There was an article that was looking at anesthetic doses that kind of their consensus was to avoid it in congenital long QT due to its symptomatic effects, but I generally am not it's not something, since it's so limited case reports and it's more in the anesthetic dosing, it's not something that I think, it's not something that you need to really focus on. If their QT is prolonged, but they are otherwise, this seems really like a really appropriate option for them, I don't think I would let that stop you from trying it. Um, there is some theoretical risk about patients with increased intracranial pressure. I think the data is quite mixed on that. And I know actually Dr. Rowe has a great story of a patient with a lot of brain metastasis from their cancer. And so the increase in intracranial pressure was a real concern, but she was not controlled on many other agents. And so ketamine was the one drug that actually finally controlled her headaches. And so it's more of a theoretical risk than an actual risk of the intracranial pressure. And so but something to keep in mind, but always with our patients, you're weighing the risks and the benefits. So what does the evidence say? And so these are looking at some different looking at some different pain syndromes. And so I'm going to kind of breeze through this a little bit. In patients with CRPS, it did show pain benefit, but it did not, there was a study that did not show any improvement in functional status. Many of the studies kind of looked at patients, this neuropathic pain random controlled trial was 42 patients, and they were randomized to 3 milligrams of methadone, 30 milligrams of oral ketamine, or the methadone and ketamine. All three groups had decrease in their pain scores without statistical significance, but the ketamine alone reduced the incidence of allodynia. There was a small case series on 32 patients with post-herpetic neuralgia and diabetic neuropathy. They received 150 milligrams daily of ketamine, and at 3 months, they had decreased pain. Post-thoracotomy pain syndrome is one that we see quite a bit, I would say. And so there was one study that did show pain improvement at 30 days compared to placebo, but not at 3 months or 6 months after the ketamine infusion. And in general, meta-analysis and trial sequence analysis of randomized controlled trials on ketamine concluded that ketamine was ineffective at 4 weeks for chronic non-cancer pain. But when studies excluded a high risk of bias, ketamine was found to decrease pain at 4 weeks with a moderate level of evidence. And so I kind of put this in here to say, I think if you're going to see this data is all over kind of whether it's helpful or not. And a lot of it is that the quality of data we have is unfortunately not great. In cancer-related pain, I have a new study on my next slide that I'm going to share with you that I found very interesting. But there was a 2007 Cochrane review that showed that stated that the current evidence is insufficient to assess the benefits and harms of ketamine as an adjuvant to opioids for the relief of refractory cancer pain. And they point to the low quality of the evidence. A lot of times what we find is that randomized controlled trials have not shown any benefit, but there's a lot of case reports and case series that demonstrate a positive impact of ketamine on pain. And a lot of this I attribute to we haven't had standardized dosing. And so, sometimes you read a study and you're like, did that not help? Because in my mind, they underdosed them or we haven't had that standardized dosing where we're all looking at the same doses. This is a new study, and I just found this really interesting. So this was a 2024 systematic review of ketamine and cancer pain. It came out just like right after I gave my talk last year. And they found 35 studies. It included 2,279 patients. The dosing strategies varied. So they had patients on, it was a lot of patient-controlled analgesia, which is not how I use ketamine. So they had patient-controlled IV analgesia, patient-controlled epidural analgesia, patient-controlled subcutaneous analgesia, and then some oral ketamine as well. And so their kind of overall conclusion, so the plot, figure 2, so the one on the left is looking at the visual analog scale. And so they concluded that ketamine was effective, but of course more high yield studies is needed. But when you took those studies and you broke them up, so the graph on the right breaks them up by the mode of or like the route of administration. And so this top group here is the patient-controlled IV analgesia. And so what you can see here is that it really, when you looked at those studies, um, it it crosses the midline. And so it did not show that patient-controlled IV analgesia was better than placebo. When you look at epidural administration, this actually does show to be significantly shows that ketamine is significantly better than placebo. Subcutaneous, again, administration crosses the midline, no better than placebo, and oral crosses the midline, no better than placebo, even though there's only 2 studies in that arm. And so it kind of seems as though that epidural administered ketamine kind of is skewed for all of the rest of their studies, was kind of the conclusion that I came to. And so I think, again, more studies needed. There was, interestingly, fewer adverse events for patients that received ketamine over patients when they looked at patients that received ketamine versus opioids. Mostly like pointing to there was less nausea with ketamine, less constipation, actually even less hallucinations with ketamine than with opioids. So, I mean, it may be safer than opioids in some ways, but unclear if it is effective. I did look, because using ketamine as a patient-controlled analgesia is kind of a novel concept to me. And so one of the studies, they used 0.3 milligrams per kilogram per hour, kind of as a basal infusion, and then the patient could push an additional 10 milligrams every 10 minutes as needed, which I thought was pretty aggressive. Yeah. But because I mean, upwards you could get 60 in boluses, so 60 milligrams an hour, which is a lot. So another study used 2.7 milligrams per hour, and then they had an additional 2.7 milligrams every 15 minutes. That seemed to me to be a little bit more, I guess, a little bit more reasonable. So, and then looking at acute post-op pain. And so these, I think I'm just going to kind of summarize. I actually feel like the data for acute postoperative pain using ketamine is overwhelmingly positive, I would say. There was a 2018 Cochrane review that concluded that ketamine probably reduces postoperative analgesic consumption and pain intensity. I found a couple newer meta-analysis, and this is from one of them, and is interesting. One focused on just abdominal surgeries, and the other one kind of looked at a whole variety of surgeries, and they came out around the same time, and their findings were almost the same. And so they found that rest pain at 4, 12, and 24 hours significantly improved with those that received ketamine, but not placebo. I would say the one caveat is with this study, the patients, some were receiving ketamine just during the duration of their surgery, while some received ketamine up to 48 to 60 hours after surgery. And so there was quite a bit of heterogeneity amongst the studies. I think from our standpoint, I would like to see more studies that focus on the, receiving ketamine post-op, like after the surgery is done. But even those that received ketamine during surgery and it stopped, had improvement in their pain scores. At 4 and 12 hours post-surgery, the consumption of morphine was reduced in the group that received and this was an S-ketamine, that received S-ketamine, but there was no difference at 24 and 48 hours. And I think that's because a majority of the studies, again, they were only receiving ketamine until the end of surgery, but there was a handful. This is from the study that had a variety of surgeries, but even the study that looked at those that just had abdominal surgeries had essentially the same findings. And then post-op complications were actually similar between the two groups. So ketamine didn't increase the risk of post-op complications. Um, so, back to our patient case. We actually on post-op day 2 started him on IV ketamine at 5 milligrams an hour. We reassessed the patient later that day, and his pain was a 0 out of 10. Remember, it was a 7 to 9 out of 10 before we started ketamine. Unfortunately, overnight, he had some ST changes on his monitor, and ketamine was discontinued. Obviously, hindsight's 2020. I do not think those we did not believe those ST changes were related to ketamine. The next morning, his pain was severe again, 9 out of 10. His OMEs were 180 in those last 24 hours. We restarted the ketamine at a lower dose, this time 2 milligrams an hour, and we noticed he had significant reduction in his OMEs in the next 24 hours down to 80 OMEs. The patient, unfortunately, he had hallucinations. He was also having hypoxia and mucus plugging at that time. And of course, hindsight's 2020. So we didn't have the most success keeping him on the ketamine. And he remained off the ketamine and did quite well with opioids after that. But I put this case to show because we did see a remarkable reduction in his OMEs with ketamine and an improvement in his pain scores. And so I think that is how, one way you can utilize ketamine in your patients. So,
Kayla,
yes.
Quick question. You had mentioned that he had some hypoxia and mucus plugging. Do you attribute that to, I don't believe that would be contributed to by the ketamine, would you?
No, there is no. So ketamine doesn't decrease the respiratory drive as we can see with opioids. And so we wouldn't have expected the ketamine to have that impact. I think it was, I'm trying to think, he might have either had some underlying lung disease or just the fact that he was in the ICU in bed
Sure.
and not moving.
So really it's mostly the psychosomatic effects that really caused you to have to tail back on that.
Yes, I would say it's the psychomimetic. If you start increasing your ketamine too much, generally patients are going to start feeling dizzy. They're going to start having vivid dreams. They're going to just start feeling weird. And so that's kind of when I start peeling back on my dosing. So that's what I'm assessing for when I'm checking in on patients on ketamine. Are you feeling dizzy? Are you having vivid dreams? Are you having hallucinations? Are you having increased anxiety? And those are kind of the things that I'm most looking for.
Thank you.
Yep. We have a depression case here. So I have a patient, DW. She's a 73-year-old. She has a history of hypertension, coronary artery disease, hyperlipidemia. She was admitted with a perforated diverticulus, underwent surgical intervention. Her hospital course has been filled with complications, including poor wound healing, but her overall condition is improving and she's nearing discharge. So we're consulted on day 27 because she's been refusing to get out of bed, work with PT/OT, and she's really not eating. Her goal is to return home. So she wants to get her strength back to go home. You rule out that there's any unmanaged symptoms contributing to her immobility and poor oral intake, and she describes to you that she's feeling hopeless. So what would you do? And so ketamine for depression. So this is where a lot of the research has been over the last, at least the last 5 years, is looking at how we can use ketamine for depression. So this is kind of where you start seeing, and when we started looking at ketamine for depression, everyone kind of started standardizing the dosing a bit more to use that 0.5 milligram per kilogram. There's been studies that have looked at single doses, just giving 1 dose. There's been studies that looked at multiple doses, so giving every night oral ketamine. And they have all been pretty positive. And it's also felt that 0.5 milligram per kilogram of IV ketamine is about equivalent to 56 milligrams of S-ketamine. And so this was a nice review that was done a few years ago. And so what this showed, there is a lot of different dosing strategies here, but this study looked at different time points. So like 40 minutes, 4 hours, 4 days, 2 weeks, 6 weeks. And so they look, so all the blue boxes contain studies that showed a positive benefit of ketamine at those different time points, where the red or orange boxes are studies that did not show that it was efficacious. And so, as you can see, the positive studies in depression, even at 40 minutes after an infusion, outweigh the no efficacy studies. And when you compare, when you look also with ECT too, there did seem to be some benefit in with ketamine in combination with ECT as well. So, and because it can work so rapidly within 40 minutes, it can be helpful for someone who is having acute suicidal ideation. And so I think that's kind of the next frontier of ketamine, is giving ketamine like in the emergency department to someone who's acutely suicidal. And so all of this has led to a product called Spravato, or S-ketamine. So this is the S isomer of ketamine. It is FDA approved for treatment-resistant depression, which is defined as no response to 2 or more antidepressants. It is an intranasal preparation. It does have to be given by a licensed psychiatrist. It is monitored therapy, so it's given in the office, and they are monitored for I think about 30 minutes after they receive their dose of S-ketamine. The prescribing physician has to have a mechanism. It's a monitoring system with opioids or with controlled substances. So there has to be kind of they're having it in-house, and it's like called a REMS monitoring system to legally be able to prescribe it. And the number, so this has been shown. So as you can see here, in the response rates, looking at 2 weeks and 4 week studies, the number needed to treat for S-ketamine is quite good. Here it is 3 to 4. At worst, it is 9. The number needed to treat for an SSRI is 7, and for TCA is 9. So even at the worst end, it is better, if not equivalent, to what we have on the market for depression. The number needed to harm is 178, which is not significant. And so this is where they give the 56 milligrams, followed by either another 56 or 84 weekly for 4 weeks, and that's your induction phase, and then give maintenance weekly, another 56 or 84 for weeks 5 through 8. And then if people are needing treatment beyond that, it either goes down to every other week, or some people continue on weekly. This was just looking at this this trial looked at using ketamine on, and so this is not the Spravato, but just ketamine in general for maintenance therapy for depression. And essentially they found, this is the number of people that were treated for at least 6 months and had a sustained response, 6 months to a year. In the studies that looked at a year, that was their sustained response to ketamine. And so it is showing that, this kind of case report did show that it can be helpful for some people for even up to a year or beyond. And so there's very few adverse events with ketamine when used for depression. And they are looking at using it for unipolar and bipolar depression as well. So back to our patient, after our discussion, she's agreeable to starting an SSRI and ketamine, 0.5 milligram per kilogram of her ideal body weight that I ran over an hour. The next day, she reports she's feeling about the same, but the nurses notice some subtle improvement in her cooperation with cares and oral intake. She's agreeable to a second bolus. And so I repeat the same dose, a 0.5 milligram per kilogram and of ideal body weight, and run it over an hour. And actually, the next day after that, she did report an improved mood, and she actually agreed to work with PT. And then over the coming days, her intake and her cooperation with nursing and therapy improved, and she was able to discharge to subacute rehab, which was what she was hoping for. So I do think for our patients who have been in the hospital, they're just, feeling quite depressed and despondent, that ketamine can be a helpful tool to kind of acutely lift them out of that and help kind of get them back on the right track to meeting their goals. I won't go into this, but this kind of just shows, so the green line is midazolam. So this is in patients with PTSD. I know that's not a lot of what we treat, but I think it's just cool to still see that compared to midazolam, ketamine did have significant improvement in their scores on this CAPS-5, which is a PTSD measurement tool. So it did help with PTSD symptoms. And this was, there was only 30 in the study, but they were looking at infusions of ketamine, a 0.5 milligram per kilogram weekly. I have another case. So this patient, I'm just going to summarize. So she was a 76-year-old with breast cancer, and she had some pain in her right oblique, right side of her torso, which was a sharp stabbing pain. She was not able to tolerate a bra or a shirt, as the lightest touch worsened her pain. And she has tried many things and has not found a lot of relief. And so what might you do? Well, I started her on this topical cream that's ketamine 10%, clonidine 0.2%, and gabapentin 6%. In our community, this cream is lovingly called the Mulder cream. John Mulder came up with it, and this is the cream that is my go-to cream. Unfortunately, I think I would use it more if insurance covered it, but they sadly do not. So I did start this cream on this patient, and when I followed up with her, she actually had reported it had been very helpful. She was able to tolerate wearing a shirt. She told me she could lay on her side in bed. She was tolerating the bedding on her chest. And she was actually very optimistic that she was going to be able to tolerate getting a mastectomy bra, and was excited to start the process of getting fitted for her mastectomy bra. So just this topical cream just provides significant benefit in that neuropathic pain that she was having after her mastectomy. The data on the ketamine cream is a little bit kind of all over the place. I think a lot of times, the Mulder cream that I talked about uses 10% ketamine, and that's especially if you're not using an area of open wounds, I would recommend using the 10% cream, because I think that is where studies have shown some benefit when they looked at 10% ketamine cream versus placebo for CRPS, did show some improvement in that allodynia and hyperalgesia. And then another study just looked at venipuncture, and when they compared the ketamine cream versus EMLA cream versus cold cream, there was a significant decrease in pain compared to placebo, the cold cream, but there was no difference between EMLA cream and ketamine. So it did show improvement in pain, although maybe not better than the EMLA cream. So in the pediatric, I would say probably the people I'm sitting in the room know more about ketamine in the pediatric population than I do, but it is safe. That is what I can tell you. There has been some studies looking, particularly this one at cleft palate repair, looked at 50 patients that were randomized to 2 milligrams per kilogram of bupivacaine or a 0.5 milligram per kilogram of ketamine that was infiltrated at the surgical site. And there were similar pain scores at 12 hours. but actually at 24 hours, the ketamine group had lower pain scores. And only 28% of the patients in the ketamine group required rescue analgesia versus 64% in the bupivacaine group. This was a study that looked at ketamine infusions. And so there were 63 children. They received, I would say, fairly small doses. So the study looked at 0.1 to 0.3 milligrams per kilogram per hour. And they gave it over 4 to 6 hours per day for 3 consecutive days. So what they found is that when you looked at CRPS versus other chronic pain syndromes, the children with CRPS had more improvement after ketamine than the other pain syndromes. When you further broke out those other pain syndromes, patients that either had trauma or POTS did have more improvement in their pain scores than those with headaches, cancer, or other pain syndromes. So I think there is some evidence that it may be beneficial for pain in children. And then kind of the elephant in the room, particularly with Matthew Perry's passing, is dependence, addiction, abuse, and long-term effects. A lot of this is unknown. It is a drug of abuse in club and rave culture. Most of the data we have on these long-term effects and addiction abuse is in mice. There's really only case reports of withdrawal, which may be palpitations, tremors, sweating, anxiety, depression, and insomnia. For Matthew Perry, he reportedly had anesthetic dosing in his system when he died. So generally death by ketamine overdose is rare unless there's other substances. So summary and thoughts. The literature on ketamine uses a wide variation of dosing strategies. But as I said, we're kind of standardizing dosing a little bit more with the 0.5 milligram per kilogram being kind of our starting point. And then for IV boluses. And then many of the reviews on ketamine point to low quality evidence and conclude more studies are needed. I would say consider ketamine for depression in hospice patients with a life expectancy of days to weeks, because as we saw, it can help pretty quickly in depression. And I anticipate its use in depression to expand. And despite evidence for ketamine in cancer patients is inconclusive, I do feel there is a role for ketamine in patients who are not responding to opioids or experiencing opioid toxicities. I also should have added here, I also recommend for those patients who are post-operative using ketamine for kind of opioid sparing post-op pain management in the 24 to 72 hours after surgery. So I have lots of references here. And as I say every year, hopefully you're feeling a little bit more like my black cat Luna about ketamine and less like my wild Savannah cat. So I'll take questions, or if my pediatric colleagues in the room have any other thoughts on ketamine in children.
I'd love to hear that. Yeah, no kidding. Okay, you can probably go ahead and get rid of the screen share there, Kayla, and we'll open up for questions and comments from the group. I really appreciate you doing this. It's such an important tool in our, in our quiver here. And one of the things that I find fascinating is, and I appreciate you kind of, directly addressing that we don't have a lot of the, what I would say, traditional evidence basis like we might have for other drugs, other diseases, and other circumstances. And yet we still find it to be an extraordinarily valuable tool. And I think that's kind of one of the challenges that we've found in palliative medicine almost from the beginning of the specialty, is that we have this not only intuition, but we have good science which suggests why it might work. We have great anecdotal evidence. We have great case control studies. We just don't have some of the way that we sometimes like to box and package our scientific evidence to prove in some terms. But it's I certainly have found it to be very, very valuable over the years. And so appreciate you doing that. So I'll shut up and open up for questions. There's one posted here, Kayla, from Andrea. I've had a few patients ask about this in the outpatient setting. Any recommendations on where I should refer them?
Can you hear me? Can they hear me? Yeah, right. Okay. Yes, so there are those ketamine clinics that I kind of referenced at the beginning. I mean, those are pretty expensive. In terms of in town, so that would get someone an IV infusion of ketamine is what they're offering. I have patients, some who are on oral or sublingual ketamine, and you can either of the two compounding pharmacies, Keystone or Rivertown, are able to compound ketamine. So that with a prescription, patients could get ketamine at either of those two places. Insurance unfortunately doesn't cover it. So in my experience, it was about $70 would get people like a pretty solid month supply that depending on how often they're using it, they may be able to stretch out for 2 to 3 months. But I know that's even that $70 is still cost prohibitive for a lot of the people we see.
I would also encourage folks, I think we have, if I think about the ambulatory palliative providers, Corewell certainly has an ambulatory palliative practice, Trillium Palliative Services over at Holland Home, Keystone out of Holland. The providers in those palliative areas all are comfortable prescribing ketamine. And so those would be an option. You're correct about the cost and whether you're talking about just the plain compounded, liquid ketamine to do sublingual or the ketamine cream. It's going to be somewhere in that $70 to $100 depending on how much they're using. And I think that it's still worthwhile talking with patients about that. We make some presumptions sometimes about what we think is costly and what people may or may not afford, but I think we need to put it on the table to give them options to choose if they want to adjust their discretionary spending to allow for something that might have some great potential benefit for them. See a hand up, iPhone 4. There down. And then over to David.
Unless that's just the cursor.
Yeah, or it could be legacy. Go ahead, David.
It's been a long time since I knew neurotransmitter biology, but why does it work in depression?
Oh boy.
Yeah, so it is a little bit of some of the increased brain-derived neurotrophic factors. I think it relates a lot to just some of the neuroplasticity of the brain and strengthening the synaptic connections. And so when we start strengthening those connections, that can improve resiliency to stress. And the BDNF that can help with the growth, repair, and survival of neurons. And then performing new synapses in the brain and reducing that overactivation of the amygdala is how it's thought. That's kind of the most recent kind of thoughts about how it's helping with depression. There is some also thoughts that the antagonism of the NMDA receptors leads to that glutaminergic AMP receptors, which can facilitate the transcription of prosynaptogenous proteins, which can have antidepressant effects as well. And so it is very complicated. And that article in the Journal of Neurological Sciences really can get you into the weeds about how it works.
There's a question here asking about the historical context of the topical cream that you referenced, Kayla. And I'll take it back just a little bit. It goes back 25 years. And it was not a singular case. I was working within the context, doing some palliative work within a cancer center. And this was, if you think 25 years ago, this is when we were seeing a lot of the emergence of chemo-related peripheral neuropathies. And we didn't have a lot of tools. Gabapentin was still relatively new, not that in 1999, 2000, 2001. Gabapentin was still relatively new then. And so we had tricyclics to treat neuropathic pain. and stumbling with opioids, which clearly were not the ideal thing to do. Ketamine was just emerging as something that people were saying, this is really interesting, recognizing that it had this great lipophilicity and could, transmit, through the skin. And it was sort of a what if. Well, we knew that there were some other options as well. You got and the alpha stimulator, the clonidine, had some capacity for providing some benefit. We were certainly aware of the calcium channel blockade capacity of gabapentin, which also was lipophilic. And so, and I can't take, you graciously gave me credit, but it's not me. I was working with a pharmacist at the time, Phil Bradley. Phil was an innovative compounder, and we had a lot of conversations about what would work, what might work, what could work, what concentrations made some sense, going through some of the pharmacodynamics and pharmacokinetics, how much is really going to get in, is it going to influence serum levels, all this sort of stuff. There was a lot of really boring chemistry and pharmacology involved in that, and then looking to see what bench research showed about some of those things. And so Phil actually, came up with the first concoction after we talked about different things, and then I had an opportunity to try it out with some patients in the cancer center, and it seemed to work. This is a great example of when I mentioned before, we really don't have a ton of science. Would 8% work as well as 10% of the ketamine, or would 12% be too much, or even better, or 6%? I mean, those are the sorts of things which we had neither the bandwidth or the interest in nuance. We set a target that we knew would be safe for the patient, that wouldn't result in significant systemic absorption, that we estimated would be able to penetrate deep enough to really attach and affect peripheral neurons, and we got positive results. And you'd mentioned earlier about opioid sparing. It did just that. We saw patients that had been on.
You're listening to.
We saw patients on high doses of opioids and gabapentin that were able to almost virtually.
Yeah, I'm going to pull that article.
Get rid of all of that. So we were able to get rid of a lot of that stuff on a lot of patients, and so that's sort of the background of it. And with success, you just keep doing what seems to work. And so I've used that for a long time.
I have just a corollary to that. If you're going to go with a topical, should you just go with the Mulder cream, or can you just do ketamine by itself?
You can do ketamine by itself, and in fact, if you talk to Kayla mentioned the ones in town that do compounding. There are dozens and dozens and dozens of different formulations that others have come up with, and they are in a very similar realm. Someone thought this would be a good idea. They tried it and it worked, so they do it. Okay, but no one has ever, to my knowledge, taken, for example, a combination of 5% ketamine plus a tricyclic topical, which you can do, plus a local anesthetic, which you can do, and a little steroid, and compare that to something else. Those types of comparative studies just don't exist. But what I have done over the years, there are just one last one that I'll mention. We had someone that had a leaking peg tube, and it was causing massive excoriation, and we couldn't get a gastrostomy tube large enough to seal, so they were getting a lot of leakage of stomach content onto the skin, and it was excoriated. It was burning. It was very, very severe. And so in that particular case, we thought, well, we need more than just the ketamine. So added a little steroid for the inflammation, added a little topical methadone to that. And it worked great, and a little local. I think it wasn't lidocaine, but one of the other cane preparations. And those are the sorts of things you can do with compounding, and which I think is so beautiful about if we can imagine what the pathophysiology is of this topical insult, and what sorts of strategies might counteract what the pathology is. You can put that in the cream.
I would say too, anecdotally, when I was doing hospice work, if we had patients with complex wounds, I was using a topical ketamine spray and it was just ketamine. And so I would usually talk with the pharmacist about the percentage. So I can't give you a percentage kind of based on like the size of the wound and the frequency of application. But we would do that for dressing changes. And I would say anecdotally, I had a lot of good results. I know when the goal is trying to heal those wounds, a lot of times the wound team doesn't want you putting stuff on the wounds, but when our goal is just to palliate the wounds, knowing that they're not going to heal, I did find that that ketamine spray was very effective at managing wound pain.
Yeah, and that concentration is 100 milligrams per ml, and they put it in like a little spritzer atomizer, which has a metered dose when you spray it.
Mike used it on somebody in the community.
I've been using
This is Ken Hansen. I'll comment on, I use oral ketamine, swish and swallow, just 10 milligram solution for like oral mucositis. And that helps a lot as well.
So,
I've been using ketamine at Trillium Woods for over a decade, and I found that the 10% works the best. And I also find that if you use it at least 3 times a day, I get the best result. And if it happens to sting on an open wound, you just switch to a cream. But the spray is pretty easy to use.
I think there's another question there or another comment.
I was just curious if anyone's used ketamine via the epidural route and if our anesthesiologists are willing to place an epidural just for ketamine.
Yeah, I have not personally been involved with ketamine epidurally. I like the idea, but again, the technical aspects, as you comment, like you have an anesthesiologist who's going to put it in and help you manage it.
I have not either, but I'm like after that review from last year at cancer-related pain, and really that epidural was the only ketamine that really showed significant improvement over placebo. I am now like definitely going to look into it more and see kind of what our options are for that.
Well, great job, Kayla. I really appreciate you delivering this lecture. It's important stuff, and obviously the dialogue will stay open as we continue to share our experiences with each other and continue to move this important opportunity forward. So, thank you all very much.
For having me. Have a great day, everyone.